And now I would like to invite Dr. Raju regarding to talk about Rhegmatogenous retinal detachment and peripheral retinal regions and how to prognosticate.
Thank you, Rama, for having me in this session. I'll be trying to briefly cover an vastly and extensive topic of both the peripheral retinal lesions.
The other mic is not on. The other one.
Probably an extensive topic covering both peripheral retinal lesions and Rhegmatogenous RD. So if you look at the peripheral retinal lesions, they are primarily classified as trophic tractional or trophic tractional, or sometimes as where they are from intraretinal, vitreoretinal, and chorioretinal degenerations. Based on this, you have these anatomical classifications also. But what really matters is when we are in our clinic is what is clinically benign and what is clinically significant, for which in those patients I need to spend that extra time to talk to the patients. So this classification is what we would have in our mind mentally. So if you look at the clinically benign lesions, these are the microcystoid, snowflake, paving stone, drusen, honeycomb. So in these patients, we would usually not be worried too much because these are not likely to progress to any significant retinal issues in future. So you have the white without pressure, wherein it's mainly changes are there in the ellipsoid layer as far as the OCT has been done for the peripheral lesions in these patients. Again, microcystoid degeneration, again, it's also considered benign and no association with vitreous detachment or systemic conditions or for retinal holes in these cases. If you see the clinically significant lesions, two important questions that we should answer is, what is the risk of progression to a retinal detachment in these patients, or a risk of a retinal detachment per se, or should I treat this lesion to prevent it from having a retinal detachment? So if you look at some of the lesions which are significant, some rare ones I'll start with is the vitreoretinal tufts, which could be cystic or non-cystic. Here these appear as nodular elevations in the periphery, and these may have traction. Vitreoretinal tufts will have traction, and these may predispose to retinal tear or operculated hole or a detachment, especially when they have PVD, along with PVD. So when we see these patients along with the PVD, so then we should look carefully whether there is a tear in these type of lesions. And however, the risk of developing a RD is less. It's less than 1% or 0.28% has been reported. Then other lesions are the meridional complex with a hole, the oral base. The oral base are small eye lines which are adjacent to the two dentate processes, and prognostically tears can be associated with oral base in 0.5% of these patients, and oral base again with associated with the posterior vitreous detachment had at least one tear associated with the base. So whenever you find these, then we have to be careful and tell the patients that whenever they have these symptoms of PVD, they should visit us. Coming to the lattice, it could be typical or atypical, and atypical ones are the higher risk for retinal detachment. So whenever we have patients having a radial lattice or along the vessels, then we should ask these patients to come regularly and watch for any holes in these patients or tears. And it can also be seen in Strickler syndrome. However, the lifetime risk of RD in a patient with lattice is less than 1%, but we have to look at the other things like the vitreous adhesion at the borders. It plays an important role along with the retinal thinning, which can happen with time. Then you also can have tractional tears associated with lattice degeneration, and it is present in 1 to 2% of the retinal detachments. And detachments, when they have holes, they tend to occur slowly. Now, and when you compare with the lattice with tear, with holes, they tend to occur slowly, and they may have a pigmented demarcation, and they may happen in the inferior quadrants. So you have to look at the cumulative risk factors in these patients, like the axial myopia, then the age-related vitreous changes. Any intraocular surgery can substantially increase the risk. Then the tractional tears can lead to, are seen usually in patients more than 50 years old. Then if the patient has a RD or a RD with hole in one eye, the risk of detachment in the other eye is approximately up to 2 to 5%. So we need to educate the patients regarding the other eye RD also. Snail tag degenerations, you may find small holes, but these are not associated with RD, and prophylactic treatment is not necessary in these patients. Again, when it comes to typical retinoschisis, these are usually shallow, while reticular are usually bullous and can extend beyond the equator. And here again, if you have a break in the inner layer, there is no treatment required. And 16% of these patients can have holes in both the layers and can lead to retinal detachment. When it comes to retinal holes per se, these can be divided into operculated and atrophic holes. And in atrophic holes, only 19 patients had, out of 162, they had a subclinical detachment and which progressed to a retinal detachment. And of the 32 patients with operculated holes, no patients had a retinal detachment. So they say that you can observe these patients unless there is a PVD in these patients. But symptomatic, you need to treat them. Retinal dialysis also we need to treat. And Stickler syndrome, ensaklage with laser can be done. As far as the peripheral screening for refractory surgery patients are concerned, so this is the recommendation that is there in the IJO now. All symptomatic and asymptomatic horseshoe tears and operculated holes and lattice degeneration with holes and atrophic holes should be treated promptly. And the risk is most with phakic intraocular lenses, followed by phaco. This is the management as per the AO guidelines, and you can have a look at that. Most of the times, treatment is only required for symptomatic horseshoe tears and symptomatic dialysis. So we need to, important to tell the patients regarding the signs and symptoms of RD in these patients. When it comes to RD, prognosticating the cases, again, two important questions. Will this patient recover vision, or what will the single surgical success rate? So important factors to consider would be the age, comorbidities, and the history. We need to be sure that the patient is giving us the correct history. And if the patient is having associated myopia, the axial length more than 26 is associated with higher risk of surgical failure in these patients. I'll take 2 minutes more, please. Yeah. Again, when it comes to retinal breaks, so it also depends on where is the break location, whether it is in the superior, inferior. But the studies have shown that with PPV, in uncomplicated retinal detachments, breaks actually do not matter much. But we do see that patients who have got inferior breaks are at higher risk of problem developing a surgical failure, having a surgical failure. Again, you can have these multiple breaks in the same quadrant with PVR or GRT or large breaks like this. These patients may have a lesser chance of a surgical success. As far as macular involvement is concerned, this is most important for the vision. And 90% of the patients with macula on RD had a better vision compared to macula off vision, wherein only 50% of the eyes could achieve a final visual acuity of 6/15 or better. So if it is macula is detached for more than 1 week, the good visual acuity can rarely be achieved. Then when it comes to PVR, we can see that all these patients who got PVR have a very lesser risk of surgical success. And if the patient has PVR say grade C and above, then there's a chance of detachment, reattachment goes down very, very less. Again, the chronic RD, these patients may have a lesser chance of visual gain because of the pigmentation, even though the detachment is shallow. And associated features like presence of a complicated cataract surgery with dislocated lens may all complicate the matters. And the choroidal detachment, if it is there, the risk is of failure is approximately 30 to 40% in these patients. Again, pediatric IDs are a different ball game, and they usually are the presentation, they have poor vision, and they gain lesser vision compared to the adults. So prognosticating RD, no matter how difficult it is to predict after surgery for retinal detachment, some form of predictive variables we need to have for patient counseling before surgery. Thank you.
Thank you, Dr. Raju. Actually, it's as you mentioned in the beginning, it's a long topic to cover, and we have many ifs and buts when we operate or when you encounter a case of retinal detachment, and even in peripheral lesions also. So I would like to hear from Sir regarding this particular topic, what we are supposed to look at a particular patient when we are, so after Dr. Raju's presentation. Sir, you are.
Sure. Mike? Yeah, it's fine. So we'll start with the prophylaxis of the lesions which Dr. Raju was mentioning about. Certain factors like that, the white tooth pressure usually is not an issue, but then if the other eye has giant retinal tear, then white tooth pressure is a risk factor. So if one eye has giant retinal tear, then I would treat the eye with white tooth pressure with probably a barrage laser kind of a laser. So current recommendation is around 8 to 10 rows of laser around posterior to the areas of white tooth pressure, decrease the risk of retinal detachment in the other eye. So if one eye has giant retinal tear. And microcystoid degeneration is usually not a pathologic lesion, but then that's the one which coalesces to cause a peripheral senile schisis. So that's something when you see schisis in one eye, we will find this areas of peripheral microcystoid degeneration in the other areas also. Though the I think like postmortem studies of 1,000 eyes showed that encysted oral bay is a risk for a retinal detachment or a retinal tear. I haven't seen one as yet. I have seen encysted oral bays, but I haven't seen one encysted oral bay causing a retinal detachment as yet. When lattice degeneration is concerned, mostly it's clear as to when we should treat. If the patient is asymptomatic, if there is family history, if the other eye has retinal detachment, definitely we would treat. Or if if there is a tear, definitely we would treat. If there is a hole associated with a little bit of fluid around it, whether we treat or not is always a question. But if it is a fluid which is around like 1 diameter, 2 diameter larger with the hole, I would treat it rather than not treat it. And then if the patient develops a detachment, then there is always we would have found it and we should still not treat it. So I would still treat it. So my dictum as far as lattice degeneration is concerned, whenever there is a doubt, treat rather than not treat. Better that like medical legally you cover your back rather than not it, because the complications of treatment are extremely low. Unless the lattice degeneration is running across the horizontal meridians, where sometimes treating with laser photocoagulation can cause pupillary dilatation and accommodation difficulties for a short period of time. Most of the time, otherwise you can treat. Very rarely patients will complain of seeing those black lines because of the laser photocoagulation in the extreme periphery, and most of them do not complain. Another relative indication for me to treat lattice degeneration if the children are traveling abroad. So they go abroad for a study and they cannot access medical care immediately, then that would also be a relative indication for treatment. Refractive surgery is always an issue. Refractive surgery, because I have had patients who have had a phakic intraocular lens implantation and within about 24 hours develop a detachment as well. So refractive surgery, I would err once again on the side of out of abundant caution and say that we'll treat these the weak areas before they undergo a refractive surgery. At least we would have done whatever has to be done. After that, they develop detachment. That's still, we have done our best. Retinoschisis, outer layer breaks, usually I would treat them, because if there's an outer layer break and an inner layer break develops, that can develop into a rhegmatogenous retinal detachment. So Inner layer breaks need not be treated, can't be treated. So if it's an outer layer breaks, then I would treat them with laser photocoagulation so that it doesn't progress to detachment. And I have seen a HST as an outer layer break also. How that happened, I don't know, but then I have seen a HST as well. As far as retinal detachment is concerned, all of us are familiar. The duration of the detachment, degree of PVR, and macula on or off are the main factors as far as the vision is concerned. As far as the anatomical success is concerned, the size of the break, and if there is associated PVR, and age of the patient are the ones which are as far as the anatomical success are concerned. And certain things I would want all of us to keep in mind. So if you see a child with a retinal detachment and a giant retinal tear, then we need to be particularly careful because these are the ones who may be syndromic. So particularly ask to see if the child has had a cleft lip surgery. If it has had a cleft lip surgery, there's a very high chance that this child has Stickler syndrome. Best would be not to go inside the eye if it is possible, not to do vitrectomy in these eyes if it is possible. If it is absolutely not possible, then of course we have to do abundant caution and take these patients up for vitrectomy. CD with RD, yes, vitrectomy has better anatomical prognosis as compared to scleral buckling. That's what one of our studies when we did what we did in Shankarnedala showed. We can treat them with steroids, but then steroids is not the only treatment. But then you do steroids, then drain the choroidal detachment, then doing a vitrectomy removes all the inflammatory mediators from inside the vitreous cavity, which increases the chances of a surgical success. Another concept is what Dr. Rajiv Muni has been popularizing about metamorphopsia post retinal detachment surgery. That is like a misalignment of the photoreceptors. So that he presumes, he says that at least his paper says that it's much worse if you were to do a vitrectomy and forcibly reattach the retina on the table as compared to a pneumatic retinopexy. So my counter would be, yes, in a given situation you still have to do a vitrectomy, but then like leave behind a little bit of fluid in the posterior pole. So let's not drain it completely dry. So leave the macula detached and use the tamponade with gas or oil, whatever it is, and allow the posterior pole to reattach by itself, then the metamorphopsia is likely to come down. So that would be my comments as far as the prognostication for Dr. Raju's talk is concerned. Wonderful talk covering a lot of aspects. I'm sure like all of you can add up to it, yes.
Anyone has anything to ask or discuss? Sir, I would like to ask regarding the quality of life post retinal detachment surgery and the vision perception by the patient post macular surgery, either a macular hole or a peripheral membrane, and post retinal detachment, total retinal detachment. So how does it changes the life of a patient, if at all, even after having a good surgery success? Does it matter? Because in the immediately post-operative period with oil also, people keep saying I'm unable to drive properly because I can't perceive something coming from this side, and there are certain particular points where they are very much worried about. So regarding the quality of life after the surgery, do you think good success of the surgery is giving a normal life, or does it anyway change the quality of life of a patient?
Almost like most of them do get back to a normal life. It's not as though unless it's a long-standing retinal detachment with PVR, and that those are the patients who have probably got about 660, 636 vision are the ones who may be affected. But otherwise, like with a young patient with a fresh RD, with no PVR, they get back a reasonably good vision, and it's not as though we cannot expect them to get back to normal life within the next 3 or 4 months. The vision continues to improve over the next year and a half. So they go on to lead a normal life. I wouldn't think that they go on to have an abnormal life. I have had patients who are doctors, who have had surgeons, who had one eye retinal detachment. They've gone back to doing their surgeries. So it's not as though it's so difficult. Certain aspects are there. Of course, if we do a scleral buckling, there may be an anisometropia. And of course, if you do vitrectomy and oil, there can be anisometropia, which would have to be taken care of. That's something which I tell them. So I prefer buckle most of the time if it is possible, and only if not possible, then I go for a vitrectomy. So though the buckle can give rise to an anisometropia because of the power changes, but actually the tamponade gives rise to much more anisometropia in the long run also, because they develop a cataract, and these patients are myopes in one eye. And if you do a cataract surgery, then again results in a anisometropia. So wherever it's possible, I prefer a buccal surgery. Yes, Manisha.
So many a times post-RD surgery, the anatomical picture looks very good. But the visual improvement is not so great, and you get a re-refraction done, still you are not able to really explain why the visual recovery has not been so great. So what are the things you would rule out in such a situation, sir?
Again, preoperatively, the duration of the surgery, duration of the this RD which has been there, and if there are any associated problems. For instance, if the patient is an anisometropic, even before, they may have a component of amblyopia which was there. Second is, of course, if there was something which went wrong during the surgery. So if the intraocular pressure was high, or if there was any iatrogenic optic nerve damage, or if there was any additives which were used in the fluid or in the subconjunctival space which went to the vitreous cavity and caused another additional toxicity to the retina. So those are things which I would look at. Despite all this, yes, there is a small segment of people who continue to have the issues. One of the things we can do is to do this visual stimulation or exercises. So that's something which can be considered. So we have had patients who have not improved, and just visual stimulation, even if they are adults, so that seems to improve them. So ask them for a particular type of exercises which they do, that seems to improve your vision over the next few months or so.
And do you prognosticate your patients with silicone oil that after the removal of oil, some of these patients do show a drop of vision, sir?
Yes, I don't tell them that most of the time. I tell them the risk of a recurrent retinal detachment, which can be 1 in 10. But most of the time, because this is not a very common phenomenon, yeah, it's extremely difficult to explain to them. It's extremely difficult to explain to them after that happens. But before that also, it's very difficult. So I don't tell them that like your vision may go down after the surgery.